So should we get going?
Yeah.
Okay. So for those of you who are joining us from off campus, we're just having a bit of technical difficulty with the video. I think you can hear us, so just bear with us. IT's on their way, but I think we'll, in the interest of time, we'll get going with the audio portion, and we'll hopefully get the video here in just a few minutes. So for those of you who don't know me, my name is Sarah Gray, and I'm one of the 3 faculty members who are members of the HRI who have been involved in coordinating this session with, of course, Rachel and Bree's help. So myself, Chelsea Peltier, and Margot Parks. And last time, for those of you who are here, I forgot to acknowledge our sponsor, so I feel horrible. So I'm going to do that. That was for the start of our session. And so I'll do that. And after I just acknowledge that, given that our seminar series is being held here today at UNBC, on campus at UNBC, we are on the traditional territory of the Kitley-Tene, part of the Dekel First Nations. And last week, we were really honored to have a wonderful welcome from Denise McIntosh as an opening for our seminar series. So hopefully some of you were here for that. Oh, here we go. IT's in the room with us. So the Health Research Institute is an organization at UNBC that aims to bring together health researchers who may be in different colleges, different departments, on or off campus. And so this seminar series is one of the initiatives led by the HRI to try to bring people together. And so this series would not be possible without the support of these individuals here. Contributions from the School of Health Sciences, Nursing, Social Work, the Northern Medical Program, Psychology, as well as Sun Life Financial. So, are you okay there?
Yeah.
Sorry, I'm just going to stop.
No one's sharing their videos, so I don't know.
Rachel, we want this camera on.
That's the camera.
Rachel, apparently we're sharing this one.
Yeah, the only thing we'll see is whoever's sharing their video through this little part, but on their end, they'll see whatever is here. Yeah.
They can see it?
Yes.
Okay.
Okay.
Yeah.
Isn't the camera, shouldn't it be blue?
Mind if I stop it real quick and just double check?
No, you go right ahead.
Yeah, sure. Okay.
We were visible on it there for a bit.
We were waiting for you, Sean.
No pressure.
Yeah. Okay.
Oh, there we go. So we were using the wrong USB port?
Wondering where you were located on any case. So probably we're in the wrong for me across, and then how much is the other?
Yeah, what on there?
I think it's because we were using the one on the monitor.
It was, yeah, it was. No, good stuff.
Okay. Rachel, we might need you to switch the deck.
Are you ready to switch it?
In a minute, sure, we're almost there. So today it's my great pleasure to introduce today's speaker, who is Dr. Travis Holyk. I just need this piece of paper for your title. That's really all I need it for, because I know Travis. But Travis is the Executive Director of Research, Primary Care and Strategic Services at the Carrier Sekani Family Services, and he's also an adjunct professor here at UNBC. I've had the pleasure of interacting with Travis in his work that he has done to support cultural competency in our medical students within the Northern Medical Program. Travis has been engaged in Indigenous health and social research for more than 20 years. Is that true now, Travis? Oh my goodness. His master's research was engaged with the Gitxsan Nation, and his doctoral work with the Lake Babine Nation. And today he's going to talk to us about some of the successes he's experienced in engaging with research in the region. So thank you so much.
And so I don't mess this up, you're going to change it over?
Okay. Aaron, you're going to
Good.
The same thing, you'll just click down on this bar to bring up the video, but if you need my help, you can use these or that. Right?
Denise Sakuze Skaze Hadi Sootsen Travis Holyk Biskai Sashni. Hello everyone, I am Travis Holyk, and as was mentioned, I'm the Executive Director of Research, Primary Care, and Strategic Services at Sekani Family Services. And today what I'm going to do is give you some research that I've been doing, focusing on Indigenous approaches. And so I'm actually going to do this different than most of the presentations that I do in terms of having some stories and situating myself in it, which I haven't actually done previously, but I will do today. And then I'm going to focus on two specific projects that we have done with Sekani Family Services and partners from UBC and UMBC around COPD and suicide as examples of research methods that work. And some of the things that I hope you get out of it is the importance of relationship buildings, the importance of community voice in the study design so that it provides direct benefits to the community from the onset in terms of doing Indigenous research. And then I'll pose a couple of challenges at the end in doing that with the manner in which that takes a lot of time. So right there, that is my grandfather, George Hanshin. And he was obviously looking at that, a smoker, as well as worked in really dusty environments. And when he was still with us, he was very active with my children, but he had COPD, which limited the ability for him to actually play with the kids. He was stubborn enough that he would run around with them in the backyard, but we did know that he was struggling to do so, and after we would leave his house, he would have naps and things like that to compensate. And we'd also have to kind of tell the kids, slow down. So that's just a little bit about myself and kind of what brought me to the interest of COPD research. And then obviously the other important piece, if you're not familiar with Sekani Family Services, is that we serve 11 different member First Nations, basically from the Vanderhoof area all the way to the Smithers area. So it is rural and remote in terms of the geography that we do serve. I put that one picture up there because that was at one point the road going into Takla, and on the other side is the road when we had to leave Takla. So one of the things that we do when we have researchers who want to come in and do research with Sekani Family Services is a lot of times we ship them up to Takla and kind of say, if you can do their research there in terms of its remoteness, you can do research anywhere within the carrier territory. And if they're willing to go, then we know that they probably are looking for an important relationship. And so you can also see in the map there where the different communities are dispersed. A lot of them are along lakes. And this is some information coming out of one of those trips where the person hiding in the back there is Dr. Pat Camp. She's out of UBC, and she actually built a relationship with Robin Roots, who's part of the medical program here, and so was interested in doing research around COPD and had tried to develop partnerships in the South. She's from Vancouver, tried to develop partnerships and was unsuccessful, but So came up to Prince George to meet with us, and then Robin suggested that she go to Takla, which is one of the communities that Robin does physiotherapy in. So again, that idea of sending her out to Takla. And the other important thing to stress here is that a lot of times when we do research, it's the importance of direct benefits to the community. So one of the things that Pat was doing, we actually did lung health days. She also came to other communities when we were doing health fairs. We try to make our health fairs a little more interactive. So we did spirometry testing at the health fairs. And when she went to Takla, she tested 25 people's lungs. And you can see there that 16% of people had below normal lung function, and 32% had lungs that were older than they should have been. This is our advisory committee. So all of the research that Sekani Family Services does, we run that through an advisory committee to see if it's a project that the community actually wants to do. Interestingly, with the research with Pat, when we were meeting with the advisory committee, we presented our Takla findings, and then we asked people, how many people know someone who is a smoker? Everyone put up their hand. How many people are having trouble walking up a flight of stairs? Everyone put up their hand. And then we said, well, we're interested in doing research around COPD. And the advisory committee said, COPD is not an issue in our community. And so obviously I had a passion in this area. And so at that point I had to kind of say to the committee, well, hold on a second. Like, everyone is saying that these are an issue. And then the other thing that we noticed was that in our own electronic medical record, because Sekani Family Services also does primary care, so we have physicians going into the community. In our electronic medical record, we noticed that there's actually only 4% of people have been diagnosed with COPD. So we kind of said, okay, there's a disconnect between, like, basically the Canadian average would be about 10% of all people over 35 have COPD. We only have 4%, and our communities are saying this isn't a concern, but we know that people live in dusty communities, work in dusty things like mills. Smoking is a huge concern in our communities, but we're not seeing that identified. So it's one of the only times, and had Pat not come to the community and I knew this is someone I'm willing to step up for, it probably would have died right there. And had I not had a passion, it probably would have died. But I said to the committee, we really need to think about this one and actually potentially do this research. Again, it was doing spirometry in the community, so direct benefit kind of hit all the tests that we do. And so after talking to the community about that, the community eventually said yes. Now, some people would say, oh, that's a little bit paternalistic in terms of then you're driving the agenda. But this committee definitely has the agency to say no, and if they were hard set against it, they would have said no. So it's actually like empowering the community to make those decisions. And with that, the other things that the community did do is they said, okay, but we're also concerned about some of the things like fine particulate because of the fires and other things that had happened, as well as we're concerned about mold. So if you're going to do testing around lung function with spirometry, we also want you to go in and test the houses for mold and some of the things that are contributing. So the committee actually built on what we were doing. And so it definitely is that partnership to the research that we were doing. So the objectives of the study that we started was to estimate the prevalence of COPD. And then the part that the committee added was understanding the relationship between pollutants and symptoms. So we have been going in and looking at the houses, taking pictures of different mold. Pat added somebody to the team that can then analyze different things like mold, as well as the things in the air. And we've been doing both simultaneously with the community. You can also see that there's the random group and the volunteer group. So another thing that our advisory committee, in talking to them and also kind of in the way that we do things at CSFS, we wanted a random sample to actually estimate the prevalence of COPD in the community, but we also wanted to make sure that if somebody was concerned about their lung function, we wouldn't just turn them away and say, no, sorry, this isn't for you. If you're taking spirometry directly to the community and somebody has a concern, we also wanted to make sure that those people who have a concern, again, kind of taking that model of direct benefit to the community, they have a concern, they're also going to have the opportunity to have their house tested, I'm permitting, because we had a lot of people who wanted tested, and they also would have their lung function tested. Oh, I will go back to that. So now one of the things that you can see in connecting to the work that we are doing, you now see in the random sample that our prevalence rate is closer to what the national averages are. So 11.4% of people we're saying have at least some form of COPD prevalence. And then you can see there as well, the other thing that we are doing is linking results to health history. So we do ask people about their current smoking, some other questions about when they were young, to tie that, and that all gets entered into the electronic medical record. And I just wanted to show you this slide. So the other thing that we did do when we build our research program, we also move it into the service provision within Sekani Family Services. So that's another really important thing about the partnership in doing research between Sekani and a researcher is those direct results of the research. So one of the things that we are doing as part of our quality improvement now at Sekani Family Services is we worked with Pat and others to develop some indicators within our instance of MOAS to make sure that our physicians and others are following up and that the care that's being provided is improved in the communities that we serve. So we've done that with other things like diabetes as well, but it's again linking service provision to the research. The other thing that we actually are going to do is that we are hiring a nurse. So if anyone's online and you're a nurse and you're interested in this work, it's now posted to have a nurse researcher. And so that nurse researcher will be kind of the bridge between doing research, so they'll be part of doing the spirometry, but they also will be the individual that is doing the service provision in terms of looking in MOAS and making sure that when somebody does have a positive result, that they're the one following up with the physician to make sure that the physician is then following up with the patient. So they'll be scanning the records. They'll also be in charge of making sure that some of these COPD indicators are completed in the community. The next project that I wanted to talk about is our research around suicide. And this research, so that the other research, there's two different pathways where research happens at Sekani. So one is where a researcher has an idea and comes to Sekani, and we filter that through our committee to see if it's something that the committee wants to do. The other way is that the communities themselves say, we have an area of concern, we need to do research around it. So youth suicide research is an example of that, in that in around 2004, Sekani Family Services, with a push from our communities, wrote a proposal around mental health and the importance of getting youth. It was actually for a child and youth mental health proposal that we sent to the ministry. So we locked ourselves down, wrote a proposal around what we actually thought we could do to improve mental wellness of Indigenous youth. That proposal was not funded by the Ministry of Children and Family Development, but it did become a proposal that we then built on and applied to CIHR. And at that time, so when we were locked down, I had not yet met Dr. Henry Harder, but at one point, Perry Shawana, who was the chair of the First Nation Studies program, he's now passed away, but Perry said, well, let me call somebody and I'll ask him a few questions. So the person on the other end of that call was Dr. Henry Harder. So when we went to actually develop this proposal and submit it to the Canadian Institutes of Health Research, we then built Henry as the lead principal applicant for that. Obviously, we shaped the proposal a lot more with Henry's involvement, but that was an example of Sekani going directly to somebody at the university and saying, there's a real need. So again, kind of that land-based idea of getting people out on the territory. And you can see in the one picture, so it was focused on both male and female. We did winter and summer camps with the youth. The other thing that we did do was that the advisory committee said, like, we're tired of the canned research where you come in and you do assist or other training. We want something specifically for the Sekani Nations. So that's where we developed our own model based on 8 carrier values that formed the chapters of that. So within this slide, you can see on the one side, the right-hand side, is one of those carrier values and some of the lessons. In the bottom left-hand corner, that is my grandmother. My grandmother committed suicide or completed a suicide when I was 6 months old. She actually walked into the Nechako River while it was still frozen and then walked out and laid on the shore and passed away. She left a note for my grandfather. And so that definitely had ripple effects through our family in terms of when I was in grade 6, going through some stuff at school, I said to my mom at one point, you know, every time the school bus goes by, I think about just stepping in front of it. And my mom actually, when we were developing kind of the myths of suicide and also communicating with respect, she sat me down and somehow, like, she hit almost all of these dues. So it was like, while we were doing this, that kind of hit home to me as well as like, wow, I don't think my mom had any formal training, but at least she was a strong individual. Not that I was really contemplating suicide, and it actually made me feel worse in some ways because I thought, oh no, my mom's mom committed suicide and here I'm making a comment like that. So that always sticks with me in terms of when we were doing the values with the youth. The importance of having that strong person who then sits you down and asks those important questions. And that's what we were doing with the youth around the handbook too. We did a mentorship model where if somebody is down, how do you actually sit down with them and have a conversation? The other important piece of this is really about engaging in culture. And Sean will recognize all these pictures too, because that relationships piece, Sean and I did research around a medical trust. And one day we were sitting down and I said to Sean, hey, I'm thinking about taking a bunch of youth on a canoe journey. I think it would be really cool to take them down Babine Lake. And Sean said to me, well, which way are the prevailing winds? Good question. I don't know. What does that even mean? And Sean said, well, with the prevailing winds, you're probably going to want to start that way because with the way that the winds go, the waves will go a certain way. And so you don't want to work against the waves on your canoe journey. You want to actually go with the waves. And I said, Sean, you're hired. You're coming on the journey. And Sean was invaluable to those trips in terms of the things that he taught to the youth and the time that he spent with youth. So that's the important piece too, is that like we've been actively involved with the youth in these projects, getting out on the land ourselves. So in my introduction, I said that my name is B-Sky, so it actually means seagull. So you can see in the bottom corner, Wee's actually doing his seagull dance for me. And also, like a lot of times now, I'm invited to dance. That's actually in Jim and Nancy's cabin, but I thought it was a good picture, so I thought I'd add it. And then people tell me now that I dance like a seagull. Is that true, Bianca? I also wanted to share this picture because at Babine Lake, one of the other traditions is that if it's your birthday, you get thrown in the lake. My birthday is actually in December, but Darcy Dennis thought it would be funny to start singing happy birthday. And so a group of guys grabbed me and threw me in the lake, which also is interesting because if you look up the history of the Lake Babine Nation in 1906, you look up the Barricade Treaty, that will become even more funny, and I'll just leave it at that. I threw this slide in there because I thought this is a cool picture of knowledge translation as well. So that's me holding my dissertation that I knew one of my committee members. So I had a committee when I did my research made up of community to guide the research that I was doing. That's one of my committee members. And you can see Sean there too. Look at how adoringly he's looking in that, just behind me over my one shoulder there. And so that's me providing my dissertation and thanking a community member participating in. Mitch, he's got his arms crossed and he's not looking as interested in that, but that's okay. And then this is kind of the obligatory slide that if you are doing research, you also have to have some results. So I did do some of those slides too. And so those are some of the measures that we did use. Again, because it is a research project, we did do cool things like take people to culture camps and do canoe journeys, but we also then had to be researchers and do pre and post testing. So some of the pre and post testing that we did do was around depression and suicide. And so we did pre and post testing around the youth and how the canoe journeys impacted them in terms of their mental wellness pre and post. Now, with that, when you do use standardized measures like that, one thing that I always talk about is that they're not always appropriate because we did have, when doing the research, so it did show that definitely there was higher levels of self-esteem as well as lower levels of depression pre and post events. But one of the things that struck me, that the results actually could have been even better because when we were working with the youth, one of the questions around suicidality or depression asks kind of a future-focused, I can't imagine my life getting any better than this. And when we asked that question, it was actually through the qualitative research that we did, and it was by me asking the question, again, had I not been on the journey. When I met with a youth, I asked him that question, and he said, like this one, he ranked really high in terms of like, from a suicide point, I can't imagine my life getting any better than this, which to some people, there's no forward focus. But for him, back in community, he was stealing from the store to feed himself and his brother. He had no structure at home. And at the canoe journey, he did test us at the beginning, but he had meals at regular intervals. He had kind of that structured. He knew from us that we wouldn't take certain things, but we were going to be fair and honest with him. So he was saying, I can't imagine things getting better than this because actually tomorrow I'm going to be back in the community. So when he did the post test, he was like, no, this is actually probably the best day that I've had. I can't imagine tomorrow being better. The other one that we just built our own test, and we asked people, it was around bullying because that was one of the things we thought about around youth suicide. We asked them about feeling safe in the community, and we were talking about things like bullying. And again, like kind of from the perspective of youth and living in a rural setting, when we asked them, do you feel safe in your community? It was just like kind of yes or no questions or Likert scales. But this individual, after he said, no, he didn't feel safe, he said, it's bear season. They're all coming into the community. And so we really have to be on guard. So totally not what you're anticipating in terms of when you develop questions. The next one that I wanted to talk about is how we actually wrapped up the work that we did on this project. So this one is complete. And at one point, Darcy Dennis, who I've mentioned him before, he was the project manager for this. And we were driving home from Burns Lake, and we said, how would we get CIHR to pay for a hockey tournament? And from there, we kind of built the idea that, wait a second, when we were out in community, all the time they would show us, this is where we had games, or this is where the ball fields used to be. And then we also thought, in February, it's really dark and dreary. We can probably actually sell this. We have to go back to Henry, who is the one who has to work with finance at UNBC. From our end, we're at CSFS. We don't have to deal with finance. All is well and good. But how do we sell this to Henry? And so what we did do was develop a whole knowledge translation strategy of, okay, we have our results. And if anyone has done work in Indigenous communities, or even any community, when I was young, if somebody had said, we're going to present results around suicide, I would have said, thanks for the warning, like I'll go out the back door so that I don't have to tell you I'm not going. And same thing in our communities. If you just say we're going to present results, you might get 3 or 4 people at the beginning, and then probably around lunchtime, you'll get 10 more people that kind of come in for lunch and maybe listen to a couple of things to be nice and then sneak out. But with this event, we actually had over 350 to 400, Sean, for the event that actually showed up for the dinner. We had over 200 participants who participated in different activities. So Sean led the snowshoeing. You can see one little girl really proud of how she did in the snowshoeing. We had fire building, we had volleyball, we had floor hockey, we had the hockey tournament, which you can see me standing way off to the side, so I'm not going to get hit by a puck. But that's really important as well in terms of the different things that we do, where when you're a researcher and you're kind of seen as a geek in the community, I don't know if people even use the word, but like a researcher, it's good to actually be involved in hockey and other things where then they're like, oh, okay, this guy isn't as dorky as we actually thought. So I did go and play in some of the all-native tournaments with the tribe, really tried to immerse myself in the community, but even at events like that, be part of the community where you're being seen a little bit differently. And the flag waving there, you can see we did an opening ceremonies with an oath, again, with the idea of really launching the project. And I'll show, keep an eye on some of the slides where there's actually posters. It's for the second project. But those posters, we almost did it like a conference as well. So we hosted a dinner and we presented results by a formal presentation like this. But we also had things like posters up all over the community, like a poster presentation that you would see at the community. And there was a few times that I would come and in between games, you would see people reading The Myths of Suicide. And I thought, damn, I actually wished I had a camera right then, because like to send that to CIHR and say, look, like here's people actually reading all about the work that we're doing. And we did do an evaluation of it at the event, and 150 filled out even the evaluation. So that, in terms of if you've done work in a community too, in one day getting 150 people to fill something out is actually a pretty good undertaking too, and speaks to the level of kind of wellness that people felt around this event. The other kind of cool link between when we're doing this with Care Sekani Family Services and the university is that this event was so successful that for the next 5 years, we actually still hosted the hockey tournament, as youth and other people would call us kind of starting in around December and say, are you having the hockey tournament again? And it was really big in terms of community spirit. So again, I talked about February being kind of a dreary time where you're kind of getting tired of winter, it's darker for longer. If you're actually doing suicide work, this made sense on that level too, that you're actually bringing some joy to the communities. So it's successful on a number of levels. With that, though, we did the youth suicide, and it was interesting because when we started our youth suicide, the big thing was the Chandler and Lalonde research around suicidality, and they looked at like some of those protective factors, and they did talk about suicide rates being much higher in Indigenous communities. But if you actually look at that research, when they looked at the protective factors, what they were actually saying was not that suicide is so much higher in communities. They're saying that certain communities have much higher rates of suicide. And one of the things that we found with the youth suicide, even though we wrote a grant to CIHR that was funded, suicide wasn't actually the biggest issue in our communities. There was enough services for youth and kind of cultural activities that were a focus that are some of those protective factors. It was actually around adults, so youth who had aged out of care, individuals who really had lost their role in community. So they're kind of that 25 to 40. Maybe they had already gone through a divorce or other things. Maybe they had children that they didn't see. They were living in poverty. They had substance misuse issues. And we actually saw that it was actually this group. So we said, okay, let's write a second grant and try to address suicide with the population that actually was the one that actually was most at risk within the carrier insecurity. So what we did say we were going to do is amend the manual that we had developed for youth. Obviously with youth, you can do more of a kind of cohort model and train the trainer, and then they're seeing each other at school and other places, so they're asking those questions. But with adults, we recognized what's a little bit different. If these are the individuals who maybe aren't working, who are a little more shut in, that you need to reach them in a different way. So the manual's got to actually reflect that. The other thing that our advisory committee said, and there's one of the posters, that this is actually for component 2, so the adult suicide, but we had similar posters for the youth suicide. The other thing that our committee wanted for this group was accompanying videos and documents. So they said, well, we want some multimedia stuff that will actually reach individuals, not just a manual. It's got to actually speak to the communities. So you can see in the one picture, Benna and others. So Tina Strudsholm was the one who was our research manager and led a lot of this work. But you can see them actually making some of the videos with the elders. And I will show a snippet that I've cut down to only a 5-minute segment of one of those videos, because I do think that they're pretty cool in the way that they ended up. Again, with this one, when we did test the manual and go out in the communities, we again did pre and post testing and saw a lot of the same results. The other thing with the manual that we did do this time was actually, like, the manual is a lot more focused on getting people out on the land, so being activity-based even in the manual. So with youth, you know, that you're a little more used to sitting in chairs and having someone speak directly to you. We thought with adults, that's not probably a format that's going to work as well. The other things around there, around strengthening relationships, like we brought community members together, and the results in some of the qualitative work that was done supported the themes of identity, balance, and connection. So people felt a lot more connected to the community. I should mention that, again, that the manuals are based on carrier values. So it speaks about the potlatch system, and then also is done in a way that focuses on being proud of being carrier. So with this one, the reason that we called it Strength Within was that we thought we're not going from that deficit-based model anymore. Everything is going to be strengths-based. What is it that makes your community cool? And I think on that one slide there, maybe you can see, like, even doing some of those kind of mapping of what are some of the strengths in your community, or taking people out on the land. Like, look at this beautiful territory that you have, and the importance of water to spirituality. And so really focusing on the strengths that make up a community. Again, you can see people in their regalia too. So the drumming and the singing, and those things that really make carrier people or DAC health people who they are and that strength within. Then we had another advisory committee, as well as throughout when we were saying, okay, we're going to be in Stellantis to do a suicide workshop with people 25 to 45. On Facebook, we'd get feedback. That's a very neato or white way of doing things, to have a focus on only 25 to 45. We have people who are 50 who need this too. How dare you be so exclusionary? We also got that feedback when we were doing the youth camps, but like when we actually did the youth camps, there was a lot of, we did do a camp where it was male and female, and there was a lot of chest bumping, potential fighting, didn't want to have babies in 9 months. So the elders said, like, what are you doing in terms of having a canoe journey with only men? But this is, they kind of like, there was the, this is like residential school when you're splitting up like brothers and sisters and others. And we thought, well, yeah, that's fair enough, good comment. But in this case, like it's kind of tough to have everyone in one canoe journey, so we did separate it. And there are times like in Carrier 2 where there are certain roles for men and women, so sharing certain things among women is appropriate too, but we did kind of get hammered for that. And then we did get hammered for basically only focusing on one age group, even though at the time the advisory committee said, yes, this is a good idea. So what we did do was we said, okay, now we have a youth suicide manual, we have an adult suicide manual, the community wants us to keep going, let's actually work with that group that we missed, the elders, and that fits with a carrier worldview of kind of a holistic approach. Mary calls it cradle to grave, that you're providing services kind of, or womb to tomb throughout, and everything is connected, that now we essentially are doing that in that we have manuals for each generation. So that project actually is just getting started, working with our elders and developing what we actually will do with them. And based on the success of our first event, it wasn't as difficult this time around to sell people on the idea of, again, having an event. So this time we chose a ball tournament, just to mix it up. And I think Bianca, who led the ball tournament, also said, I think I'm a little bit better at organizing a ball tournament than a hockey tournament. So she was really pushing for doing it in the summer as a ball tournament. And there you can see one of my daughters actually played as well. So again, kind of that bringing the whole family into the work that you're doing. We presented the results in much the same manner, although after being in the sun for a few days, I think Henry and I both shortened our presentations because we thought they don't want to hear it, and I don't think we want to go through a full hour presentation. And so I will go back here. So you can see on the dugout as well, kind of the same thing at the different events in different areas. We did have the posters up again and kind of had it as like a presentation of the results in different formats. We had a little booth where people came and asked questions about suicide and had an opportunity to win door prizes and different things. So again, always trying to kind of really present the information in a unique way. And this is an example of one of the posters a little bit bigger so that you can see it. And each of these has an accompanying video. So I'm not sure how to exit out of this, but this is the time that I do want to show one of the videos, and then I'll go back. Yeah, look at me go.
Let's see how the volume is, Will.
Okay. Well, if that's the slide just slow for a bit.
Is it going?
Mm-hmm.
Weird. here's something.
I think that's next.
Maybe. Pull it up.
Mm-hmm. No techie shown. Okay, well, we'll start that over, and I think we're good. I'm not touching anything else we got bothering me. So that's just a snippet of the video, but I did want to kind of touch that. So that's actually filmed over at the pit house that was a project here. So that's why there's slides and everything around Irwin there. But yeah, so again in there, Irwin is talking about the importance of culture, his journey in learning the language, building himself up to being on chiefing council, being a council member, the importance of his family. So I do think that was a good snippet to show of some of the messages that we're providing back to the community. The other videos are around some of the values like sharing, caring. So this is my last slide, which is really some of the key takeaways, which is that many First Nations are building the infrastructure to partner on research. So I encourage you, if you are going into communities, to find out who that authority in the community is. And it's not necessarily always First Nations Health Authority. There are a lot of community-based organizations or specific chiefing councils that have a mandate to provide that research in the communities that they serve. And by building that infrastructure, it creates true partnerships in the research that then have those spin-off benefits that I talked about around it rolling into program development. So even with other things that I didn't touch on is we do have our mental health workers that are part of the manual training, so that then it doesn't just end when the grant ends in 5 years, that it actually builds into the community, that you build that capacity in the community. And then obviously I hope the other takeaway that you actually did is that relationship building is key to being a researcher in Indigenous communities, that you can't just show up and do the research. It sometimes takes a long time to build those relationships and show that you're actually doing it from a good place and that your heart's in the right place. And so if you are doing research in those communities, I know there's more funding out there, so people kind of think, oh, I'm going to do Indigenous research because that's where some of the dollars are. You definitely have to have a passion for the work, because the flip side of it is that you can spend a lot of time building those relationships, and it doesn't necessarily always translate into grants or publications, which actually can be really hard on you as well, because if you put yourself out there and work with the communities and build a relationship and build a potential grant, and then it's not funded, it's also very difficult for the communities to understand that, well, that person came in, now all of a sudden it's not funded, where are they? So there's all of those elements as well, because as I point out here, the structure of research is not always well suited to Indigenous approaches, because you have to do potentially all of that front end work around making sure that the research actually matches something that the communities want to do. And sometimes that means that you don't actually have the funds yet to do it. Or alternately, sometimes when you do, you don't necessarily have the ability to write an ethics application that says, this is what we're going to do, and yet you're supposed to speak to the communities about what it is you're supposed to do, so those two don't always line up. And so those were just a couple of the key takeaways. And another shout out to Bianca, because that's her picture from last week that I really liked, so I thought I'm throwing that in there too. So that's Bianca sitting down with an elder doing a survey and having the D Mystique, or Labrador tea, as part of that process. So I think that captures really well how to do Indigenous research, which is build the relationship, but that doesn't preclude you from also then doing your surveys and other things. So with that, I will open it up to questions.
Thanks for sharing your story. I think that's so a couple questions. One is about demographics. You touched a bit about kind of the lashback from community when you kind of went in and said this is the demographic we want to deal with. What kind of thoughts were given to like, and I noticed there was elders on your committee around like perhaps like looking at traditional systems of plans or else, you know, looking to the matrilineal system, how they like what kind of, I'm sure you pondered that, and what did that look like?
Right. Well, and that's one of the challenges is those demographics of even a definition of a youth in a DAC health community. A youth can be someone up to 25, and I think we kind of see it as like at 19, you're leaving the nest. So yeah, absolutely, that is a challenge, and we worked with the communities, like some of those, like the advisory others, around like who should we be including, and we absolutely didn't turn anyone away. So even though, like as I mentioned, the research doesn't necessarily always line up, in that you have to write something to CIHR around who your population for the research is going to be, but that's for us not like a hard and fast rule. So actually, I don't have the slide here, but if you look at like the mean age of individuals in the second study, I think even though we said it was for the 25 to 45, I think the mean age, and I'm throwing this out there so this isn't a quote or anything, but I think it's around 45 years old, because we did have some elders who participated, and we thought by all means, like, we're not going to turn anyone away, much like with the COPD research. We're not going to say, no, you weren't part of our random selection. So we definitely, in tailoring the material, we're trying also to reach certain demographics, but we're never being exclusive. And we always do kind of debate also, like you touched on that, but I'll touch on gender as well. It's a big thing within CIHR right now. So we also, like, working with community is, do we have female only groups? And then some community members say yes, and then others again would kind of challenge us on you're being more residential schooly by doing that. But we definitely know that like women will probably share different things if it's a group of women, and the same thing with men. So we try to work all of those different demographics into the work that we're doing. That was a long way of saying that, but it's definitely a thought. And I haven't seen you in a long time, so hello again.
Well, and I'm just intrigued by, you know, like, what if we were decolonizing our research, demographics looks different. And I'm thinking about, like, even in my own experience, depends on where I'm at, is where I'm recognized, right? Mm-hmm. So in my family, I'm always learning, and I've never aged out yet from my circle, right? And so if we sat at a table and there was somebody like for a ceremony, I'm still a youth in that ceremony. Absolutely. And there are people, so that's what I would be looked at upon. I'd be the rookie. Mm-hmm. So I wouldn't necessarily take the lead. And I think that's what demographics, like, depending on the circle and how you define it. And so, you know, I'm kind of thinking when we're looking at that, it's a challenge. It is. When we're looking at, you know, that you got people who come and say, wait a sec, that, you know, like, I'm a mother at 15. And so if you want to hear from mothers, it intersects with that. Mm-hmm.
Well, and at our last advisory committee meeting, I think that we debated probably for about an hour at least around, even like with our next group, which is kind of 55-ish plus, what term we would use, whether it's elder, because then the community says, well, no, an elder is somebody who is a respected individual. You can be old and not necessarily be an elder. So we can't use that word, but we have to in some way, and then like the 55 plus. So what we did kind of settle around is exactly what you're talking about, the roles. So if it's an individual who's a bit younger, but maybe they are an individual who isn't working or like is transitioning in their life, and so they're at risk. That's the population. It doesn't really fit on a poster though, if you are like fit all of these demographics. So I mean, that's the challenge even of the language. But we had probably an hour debate just on what we're going to call the next group.
Prevention versus care. Prevention. Let's say if I'm a public health, I'm trying to come. How is this different? Or is it the difference is that you're collecting data? Because some of the questions that we talked that as discussed about the catchment, how do you define youth, whatever it is, you don't want to exclude anybody. I can see these questions. As a healthcare provider, public health providing services, you want to be inclusive as possible. But in a research setting, I think is there no value at all to have boundaries for research purposes, or is the importance of this inclusion so that we reach people more important? I don't know very much about public health research. I'm coming from a very clinical trial, clean data kind of a perspective. Therefore, I apologize for my ignorance. You're making the data muddy. I'm just.
So yes, at CSFS, there are certain times where we will do quality improvement and we'll focus on things like diabetes and making sure that everyone has their A1C, and that wouldn't necessarily be research. But when it is something like the project that I touched on with COPD, that to me and again, like for the demographic piece, is that we focused on 35 plus, and like that is like kind of the standard of you're not going to see a lot of people younger than that with COPD. So it makes like a clinical sense to actually focus on a 35 plus. But I think the part that you're struggling with is exactly what we're trying to do with research at the community level at CSFS. So something like spirometry, Vanderhoof would be one of the nearest centers that people would be able to get a test, or Prince George. And so if we just leave it to kind of the clinical side of, okay, we're going to refer somebody for spirometry because we've noticed some of the symptoms of poor lung function, we're going to end up with results of around only 4% of individuals having COPD because we're not actually getting people to those centers. So sometimes what research allows us to do is actually say, we're going to test a question in the community and then go out and bring things like spirometry directly to the community. So from my perspective, that creates direct benefits of research to the community. And we actually struggle with that because when you call it research in the community, that actually has a negative connotation. And so we have a project as well around self-screening for HPV with Dr. Shiona Mitchell-Foster. And with that project, I thought, like, this is a slam dunk no-brainer as far as our communities talked about cancer being one of their main concerns. HPV screening is like one of the like kind of, to me, the ways that you could reduce cancer rates around cervix cancer, like slam dunk for the communities. And yet, like when we said, okay, and then like for our communities as well, you have a lot of women who have had historical trauma, so maybe they don't want to go for a PAP. So you have an underrepresentation of those who have even gone and had a PAP. So I was like, slam dunk on this, like if we can do it as research where we're demonstrating the efficacy of a self-swab test. But when we called it research in the community, there were people who were opposed to it and said, we've been researched to death. And we had to say, oh, wait a second, like, yes, it's research, but it actually is service provision. We're doing it with our nurses as well. So it's no different than a nurse would do other blood work or other things if they're handing out the test. And when Shiona went out, she had groups of women who she met with and said, what do you think about this? Like, we did kind of all the right steps. We brought it to our advisory committee. We then even went out to the community, and I didn't take part in that because I thought, well, women like need to talk about this without me being there, but I am part of that grant as well. So Shiona went out and did that work. And then beyond that, I also said, like, if a nurse is providing it to someone, our communities have, like, an individual has the agency as well to kind of vote with their feet and not participate. So if they don't want to then take the test, they don't have to, but it provides another tool in the toolkit. So it doesn't necessarily mean that research has to be about clinical trials. If there's direct benefit to the communities that we serve by being able to do something that we wouldn't otherwise, that we have to couch in research, and then obviously with that, like, same thing, the results go into the electronic medical record as well as into a database of how many people have we screened, how successful is the project, doing the follow-up questionnaires of why did you choose this versus a PAP, like that type of stuff to get a better understanding of women. Like, that's a win-win in terms of Sekani Family Services. And that's like the canoe journey too. It's, I think, like, the idea is that you're providing direct benefit to the community from the onset. And we've had a shift to a certain extent. There's still individuals who come from UNBC or other institutions, I think, and still kind of say, well, like, we can't do research for research's sake and throw out some of those buzzwords that are talked about here. But at the community level now, we're getting a lot more buy-in into the research because of that direct benefit. That answers the question. It's still research, absolutely. It's just how you're moving into the community to make sure that it's beneficial and that you're focused on specific areas. Do you have a follow-up to that? I'm not sure if that answered it.
That does answer. If you come into a group with, you already know that this is going to be beneficial, but if you cannot meet the definition of benefiting the community. And in that case, are we measuring, what's the question here? Magnitude, effectiveness of the
Well, so with the COPD, it's prevalence. Right. And I wouldn't say, like, I mean, every researcher thinks that their area of research is the most important because it's what they're passionate about. So you may come in and say, this is like the most beneficial thing that the community could ever have, but that's the importance of having an advisory committee that you bring this to and say, hey, we're really passionate about this and we believe it, but is that what you believe too? And the other important thing about that advisory committee is making sure that the research actually is methodologically sound, because we have had that too, where someone will come in and say, we're interested in doing a water study, but the methods that they're using aren't necessarily sound, so that there'll be members of the advisory committee that will say, it's about water or it's about children. Yes, we've got to do this. Children and water are very important. So we also make sure that we're doing a lot of lit reviews and other things to make sure that in this area, this is the most sound research method for what they're doing.
I just wanted to say quick thanks for sharing with all your learning journey through building this partnership with all these communities. I have two questions. One is, I just really like the part where you touched on, instead of using like the suicide assist model working with kids, doing like the quite culturally theirs, like with the carrier values. Are those accessible or published or?
Yes, so we have the manual and it's accessible.
Okay.
And your lead is one of the ones that owns that manual. So.
Yeah.
Yeah.
I'll be hitting him up.
Yeah.
My second question was, I just wanted to grab the correct background. The Babian Lake history is the Barricade Treaty?
Barricade Treaty of 1906.
Okay, cool.
Yes. That's everyone's homework is to look at that.
Sort of a question and a comment. It must be interesting being you and having all the questions for the years and the research ideas for people that may or may not always be research. So I'm kind of curious, what are some of the pressing unmet research needs that you might have heard of? Mm-hmm. And just also thinking of, like I've heard Nancy saying, Travis, you've really got to research all the carrier place names down Lake Babian, and it can be awkward to say, well, that's not really research. No, it sounds interesting. Mm-hmm.
Well, I would say that still is research, but there are areas that I won't go into. So there was a time where Mabel Louie, our executive director of health, she was concerned about the food that was given out at Potlatch, that it was too sugary and other things, and that there had been a transition. And so she said, you need to do research around like where the shift occurred in the foods that are given out at Potlatch. And I thought, no, like that's not an area for me. That's for the hereditary chiefs and the clan leaders to actually come together and decide. That's not an area of research that like I think that I'm the appropriate person to do. And what was the other parts of that?
Any unmet needs that you.
So the unmet needs. Well, one of the interesting unmet needs. So I touched on the Hpv screening being cancer research in our communities. And I've touched on this before in other presentations, like cancer is one of those scary things that like you can have like somebody in community who has cancer. And so as a result, that touches like at one person, it's somebody's aunt, it's somebody's daughter, it's somebody's mother. So in a small community, they will say, we need to research like cancer as a whole, and everyone knows like that's a lot of different cancers. And then at other times, we need to research breast cancer because breast cancer is a huge issue in our community. And when we'll go in our EMR, we'll be like, well, there's been one instance of breast cancer. So the community right now would say that cancer is the biggest thing that we need to research. And so when a project like the HPV comes along that kind of is tied to that, it's easier to say, yes, the community like is already supportive of this. But it's also the challenge of like Dr. Shannon in who works kind of in the Notley area, is a doctor in Fraser Lake. She does oncology, and I've met with her and said, like, are there kind of hot spots? And she's looked by postal code and other things, like kind of like what should we be targeting around cancer research, and even looking in our own EMR. And it's very tough to say this is the area of cancer research that we need to do. So there's also kind of finding that balance that is a challenge when the community says we need cancer research. Yes.
Based on and like provide direct identity for the company. But as you said, that sometimes relation under study won't create the accurate data. So in terms of research, how could you like share your results? As the mean age of your population was higher than it should change. How can you, like in the research, and like how can you explain it? Other like
So that wouldn't be an issue for the community members, so our community members still have the direct benefits. That falls under the category of if you want to publish, that's the challenge. So we've published articles, journals, but we wouldn't necessarily get into a journal where even some of the results are pre and post testing don't have a large enough sample size even for you to be able to publish in some of like the bigger peer-reviewed journals. It would get tossed. So that would fall under the challenge of, if you're going to do this research, it can't be because you're trying to build a career around publications that are in some of the best journals at times. Sometimes you do have to kind of like eat that. The community will always come first in the research that we do. Like, we would never ever sacrifice, like, to make sure that we're like targeting a population where it isn't beneficial. So it's finding that balance and being okay with living with the fact that maybe sometimes the results aren't going to get into some of the best journals. I saw more that way too.
So, and you just touched on this because I'm curious about knowledge translation and traditional knowledge. Sometimes, like, when do you not know, like, when do you not write it down and let it be as oral tradition, right? And like when do you come across those times, like as an ethics question? Because there are some things, like you said, I won't around the population system, not necessarily think that's our goal. So there's that, and then like how do you, so nothing's lost in translation? I guess that's the fear of it, right? So like, is it just over time that you kind of, and then intellectual property, right?
Right.
So we, you know, the Western view will say that's intellectual property, and so how do you leave that where it should be, and that is with the nation? Right,
and we let the communities decide that, because even the videos, it was the communities that said, we want to do videos. And we did grapple with that exact question of, oral tradition is, if it's your story to share, you should be the one that shares it. But once you've recorded it, you don't necessarily know if it's going to be Travis playing it at an event like this. So in terms of our consents and our work with the advisory committee, we worked through all of that, and the communities decided that the ends of like having products that would be beneficial to the communities, like that videos that may empower youth or empower other people, that they were okay with using some of those materials in different ways. And that always comes from the community in deciding how it will be used. And then obviously, like from the research pieces, that your consent forms of, even when you're collecting that information, people are giving consent to exactly how that information will then be shared in a secondary use of.
That it's not about building your career. It's about community-based research.
Absolutely. Well, and some of the results that we're publishing around pre and post testing, I don't think that the community really cares about that in terms of, like, that's not that, like, when we do a presentation, they're not like, oh. To a certain extent, we do work with the community and say, like, hey, if we can demonstrate that this has benefits, that's kind of the continuity of it all, that, like, if we can show that taking youth out on the land has benefits to the mental and spiritual well-being of the youth, they don't necessarily care about the research per se, but providing them with those tools to then go to the ministry and say, we want prevention dollars, which we did do. We went to the ministry and said, we want prevention dollars, and we've demonstrated that canoe journeys and other things have been beneficial to the community. And now ISK has given us dollars to actually have the camps go on in perpetuity as part of that prevention strategy. if anyone's familiar with the court case around the discrepancies in child welfare between those on reserve and those off, that now as part of the Human Rights Tribunal, we were able to get dollars for those canoe journeys. So again, like research has different uses. It's not necessarily always just publishing in journals, which like on the academic side you need to do to further a career, but you also give those results back to the community. On the COPD, the other thing that we do is, so when we're doing the home testing, we didn't want to do damage to the communities in terms of, we really grappled with, do we provide the results back directly to the individual? Because they kind of have a need to know if their house has mold or other things, and that could be harmful to their health. But we also don't want to inundate chief and council, who will potentially have the responsibility for repairing those homes. Like, we had to really balance all of that out too in working with chief and council around how we share results at a local level to, again, not do harm to individuals, but also not do harm to the chief and council, but provide them with the information as well to go back to CMHC and apply for housing upgrades.
About your advisory council, like you have such a meaningful contribution from this group, and I just wondered, when you started the council, did you have, like, what's the composition? Have you had a lot, like, it seems like you have a very engaged group. Was that right from the outset? Did you have a lot of interest, and how do you just maintain that level of?
Okay, so with the advisory council, that actually is one of the legacies of the first CIHR grant that we received around youth suicide, was that we hosted a meeting on December 9th of 2007, maybe 6, I can't remember exactly, but we like to launch the project. And at that meeting, we asked chief and council to send individuals that were like involved in health, that were elders, that were youth, that they thought would be good advisory members for the research that was upcoming. And so through that, the other thing that we would do was that it's very expensive to bring that council into Prince George to host a meeting. So either it was through Catalyst grants, where like we would have another small research project where they could fund an additional day of rooms for that advisory council. But we basically always piggybacked off of that CIHR grant to have advisory committee meetings about other research projects. And so, yeah, they have been engaged. It was in the last iteration just now. We have had some attrition where we then put it back to chief and council, and they appointed a lot of the same people, but there are some new faces. And so that first council was basically one youth and one knowledge holder. That was part of that first council. And it often happened that like a knowledge holder, we lucked out because that knowledge holder would also be the CHR, community health rep, in the community. So we had like a balance of health, we had youth, we had knowledge holders that were respected in the community. So we gave some of the parameters, but we were also lucky that it worked out the way that it did. And people filled different roles. Like Susan Abraham from TACLA is kind of a quiet individual. So there was a couple of pictures of her in her. But at the same time, like she's very well respected in the community. So she doesn't say as much in the meetings, but if you were to say that Susan agreed with what we're doing, that holds a lot of weight in the community. And she and Sally has come out of nowhere with these like epiphanies after not saying anything that you're like, wow, like write that down, because like that's exactly kind of where we're at. So like everyone contributes, and it's really beneficial. Good.
Sorry, I don't know, because I didn't see think you probably would have done differently, or that you would recommend to be done differently, especially with regards to conducting advisory committee? I'm touching on the Hpv project, but I remember you mentioned that initially what you meant with the advisory council committee, but they don't seem to concern in the community. The way it presented in health control. And I was just thinking, is there something you would recommend that one could have probably encountered?
No, I think that one in particular was a success because when Pat had gone to the communities, I think, like in hindsight, if Pat hadn't have gone to the communities and built that relation, like already shown that she was willing to actively engage in research in the communities, that she wasn't just going to be a researcher from Vancouver that's leading a project and not going to be actively involved, that one would have went very differently. But I don't think we would have done anything different in terms of how we did it. I think that was actually one of the successes of having the information at the front end of in TACLA, like the COP rates are much higher than what we're seeing in our EMR, of like already having Pat. She went to TACLA, she came back, and that graphic is actually a big poster, and Pat came back and had a dinner with the community and shared all of the results. And actually at that community dinner, an individual came and played a guitar that evening, and we had like a full evening, and Pat engaged with the community. Like it wasn't that she just presented her results and then said, okay, let's pack up, because that's one of the things in TACLA and Yakuche in particular. They're used to people even showing up in the morning and kind of giving their presentation and then getting on the road before it gets dark, recognizing that. But like in this case, we stayed overnight, like had a nice dinner and like guitar music. It was actually a really nice evening, but it also showed something about Pat that I was willing to then at the meeting say, like, hey, I think that this is something that we need to take a better look at. Things that I would do differently with the advisory committee that we've really worked on is finding that balance of giving the committee enough information to make the informed decisions about the project, but not being so detailed. Like it's a fine balance of not being so detailed that you're also overwhelming and boring them with things that aren't as important. So being very prepared for the meetings when we do have our advisory committee meetings. And that's something that we continually try to work on.
Almost at a time, if you want. Yeah, okay.
I was just wondering, sorry.
Yeah.
I was just wondering about like how you chose your, was that yourself or was that meeting with the advisory committee?
No, that was absolutely, when I say that Darcy and I were driving back from the community and jokingly said, like, let's see if we can get CIHR to pay for a hockey tournament. That absolutely is the case. But then it was that like we had to build substance to that around the argument of why we were doing it. So that involved like making sure. But it was also informed by the fact that I had been in community and people talked about not enough activities for youth. This is where the ball field used to be. And all of those things that, like, as you kind of like built the argument in your head as to why we should do it, like everything that we were told in the research up to that point definitely supported the idea of having an event like that. And now, like when we had the second ball tournament, it absolutely wasn't that like anyone even thought, well, will this pass? And it always, like the feedback that we receive from the communities as well when we do an event like this is hugely positive, that we know we're on the right track.
So thank you so much, Travis. We'll
Thanks.
Yeah,